So we're talking about respiratory and the nursing care of a child with a respiratory disorder. We're going to be going over a physical assessment and how to obtain a health history. And these are our objectives. We need to identify certain factors that may be associated with kids that develop respiratory illnesses. We need to perform a respiratory focused assessment, and we're going to talk about common laboratory and some diagnostic testing that's used to diagnose different respiratory conditions. One thing that's really important to consider with children is that they have a significantly higher metabolic rate than adults. Their oxygen demand and requirements are also much higher than an adult. So when you look at an infant sleeping in a crib, their respiratory rate is normally going to be much higher than we would see in the adult population. So when you do a respiratory assessment on an adult and you count their rate, usually you're looking between 12 and 20, and almost everybody is somewhere around like 16 or 18 respiratory inhalations per minute. And then adolescents, we pretty much see them breathing around the same rate that adults do. So you can rest assured that at least one of the age ranges in pediatrics is going to be very similar to what you're used to. The younger the child is, the higher their respiratory rate is going to be within the normal parameters. So an infant breathing, and I'm talking about like an infant who is between 1 and 4 months of age, them breathing anywhere from 30 to sometimes 50 inhalations per minute is not abnormal, and we would not freak out about it. We don't want them breathing higher than 60 inhalations per minute because their metabolic rate is so high. We really reduce their available energy stores when they have to breathe so fast. So their rate is very important to us. They have a much higher demand for oxygen. An adult, when we're breathing, we take in about 3 to 4 liters per minute, which, hint, hint, you probably should know that for some sort of testing. Infants, on the other hand, they take in anywhere from 6 to 8 liters of oxygen per minute. That is massive, and they are tiny. So I kind of like to think about it like little hummingbird hearts, little hummingbird wings. It goes so fast, and they move so fast. So an infant, their metabolic rate, their oxygen demand, their respiratory rate, and their heart rates are all going to be much higher than a slightly older child and an adult on a normal day. So when we get into situations that are surrounding respiratory distress, like an infant who is grunting, like we talked about in the assessment. They're grunting, they're nodding their heads up and down with every breath, which we call head bobbing. They have tracheal pulling. They have multiple sites of retractions. And we can hear them and see them struggling to breathe. They will develop hypoxemia much more rapidly than an adult will. So they believe that the reason that happens, that an infant will become hypoxemic faster than an adult, is not just because of their increased oxygen demand, but also just the simple effect that the conditions that they are susceptible to place on what we call the oxyhemoglobin dissociation curve. We're not really going to get into that, and I'm not going to test you on it. I just want you to be aware that overall, the younger a child is, the faster they will become hypoxemic when they are in respiratory distress. So we're going to talk about the health history, obtaining a health history, and performing a physical assessment on a child with a respiratory issue. So when they come in for their encounter, regardless of where we're at, we're going to ask about their past medical history. We do want to include birth history in most patients that are 3 years old and under. We want to find out if they were born vaginally or via cesarean section, if they spent any time in the NICU or were premature, if they received any medications in or around their birth, and mother as well. We want to ask if they were premature and they spent time in the NICU, were they placed on oxygen? Frequently, children or infants that are placed on oxygen in the NICU and have treatment over quite a lengthy period of time, they develop what's called bronchopulmonary dysplasia. Basically, the pressure of the oxygen going into their tiny, ill-equipped lungs that do not have a fancy, adequate coating of surfactant, that oxygen can do damage inside the lungs, and they deal with that damage for the rest of their lives. We did it in the NICU to keep them alive, but it creates other issues as we go along in life. So we want to ask, not only were they premature and born in a NICU, but did they receive oxygen therapy while they were there? We want to ask if the child has a history of asthma, or what they call reactive airway disease. Reactive airway disease is kind of just a catch-all phrase for any child that displays asthmatic type symptoms in an age younger than 3 years old. Up until 3 years old, they will never say the word asthma. They will always say reactive airway disease. So we want to ask about that. We want to ask about home treatments that have been done for that, how many times they visit the hospital, the ERs, and the urgent cares in an in a year. Sometimes we find out that these kids are visiting urgent cares anywhere from 6 to 7 times a year for the same issue. And that really leads us to a definitive diagnosis of chronic respiratory disease, and we need to provide a lot of education and resource to those parents. Um, Also in the health history, we want to ask if they were born with any chronic diseases. Children with chronic lifelong diseases, even if they are not specifically related or specifically about the respiratory tract, like for instance cerebral palsy, depending on the severity of the palsy that they may have very difficult time moving their chest wall. If they can't ambulate, then that's also going to affect their lungs, right? Because if we sit and lay forever and ever, we develop pulmonary infiltrates, pneumonia, all sorts of bad things. We have cruddy chest walls that don't allow us to cough and move things out of them, and we basically fill up with grody fluid and we die. So children with chronic diseases that impairs their ability to move around or their ability to pass oxygen through their body, like a cardiac child, those kids, we really need to take into account that they are highly susceptible to respiratory illness. We want to ask about family history as well. If anybody in the family had a chronic respiratory disorder or disease, if multiple uncles or brothers or father or mother had asthma or cystic fibrosis, things like that. We want to find out if anybody in the family smokes. That's a huge no-no for dealing with the respiratory child. Then we want to talk about the history of present illness. When did the symptoms start, how it progressed, and what treatments might already have been done. So when the symptoms started, when we ask questions about that, we want to ask about the kind of um, less severe symptomatology that we might see. So like the little runny nose, a little dry cough. And maybe they had that for a week before they became very ill. Asking those sorts of questions about whether it was a very gradual onset of a respiratory illness or a sudden acute onset is going to help us to delineate between which respiratory diseases we might be seeing and which lab tests and diagnostics to do. We also want to note, were there any sick people or sick contacts in the family or friend group or daycare, babysitter, grandma's house, and how long ago that was? And we want to go back at least a month or two in this "is there any sick contacts" question. Because some people forget that a month ago, grandma had a hacking cough, lots of mucus, but she's been better. And since she got better, she's been babysitting the baby again. And now the baby is very sick, febrile, lots of mucus, tons of coughing. We don't realize as adults or as parents that we are carrying viral load around with us, shedding through our skin anywhere from 7 to 21 days after the illness has, for us, resolved. That nagging cough that sticks with you, most of the time you're still passing that to the people in your family. And unfortunately, it can take 7 to 21 days or a week to 2 weeks for most respiratory illnesses to present themselves after you've already contracted it. So a child could have been around grandma who was sick last month. The child was around her and the child was fine for 3 weeks. And then now all of a sudden they're very ill. It probably is the same illness as grandma. It took that long for the child's body to, or for the infection in that child's body to rear its ugly head. When we look into physical examination, we're going to look first at color. And you can look at the color of a child literally when you're walking in the room, right? You don't have to touch anything. You don't have to feel anything. It's just looking at their color. Is their color pink and well perfused? And is that throughout all of the extremities and the face? Great. Then we see, is there any pallor? Is there any cyanosis? One thing we do have to be aware of, though, is that infants are highly likely to have acrocyanosis, which is the bluish or purple color of the extremities. So when you take your baby home from the hospital, you might notice that their hands or feet are very different in color than their trunk. Their hands or feet might be dusky or blue or purple, and that is actually normal for a neonate, and it resolves. But if we see a 3-month-old with acrocyanosis, that should be a clue that something is likely wrong. So look into acrocyanosis and see what you find about when that should be resolved completely in a neonate, because that will help us to be able to guide our physical exam as we go along. We look at the rate and depth of respirations. So tachypnea, which is, fast breathing, we expect children to have a higher respiratory rate than an adult. They have a higher respiratory rate the smaller they are. So an infant's going to have a faster respiratory rate than a 3-year-old. 3-year-old's going to be faster than a 7-year-old. But when they are sick, they become highly tachypnic, usually often tachycardic as well. So tachypnea is usually the first sign of a respiratory illness. What's interesting is that a lot of times new nurses or people who are not well versed in pediatric care, they think that when a child or an infant goes from a super high rate of respirations down to a slow rate, that it's improvement. And slow or lower than normal rates of respiration in a child or an infant is really bad. The slow rate of breathing coming off of tachypnea is usually the sign that they are circling the drain. Their respiratory effort has just been too much for too long. Their body is too tired and now they cannot do it. So they are crumping out. They are getting ready to need to go to the PICU for sure. When we're doing our physical assessment, we also look at the nasal and oral cavities. It's really hard to look inside the nostrils of a baby, but you can tell from most older children if they have lots of snotty mucus coming out of their nose. If they're drooling, we definitely want to note that because it is an indicator of a pretty serious problem. So we don't want drooling. We don't like mucus. We want to look at the color of the drainage and the mucus. We want to look at the consistency of the drainage and the mucus. So when I suction a child or an infant, I want to say if the mucus was white, yellow, green, or brown, or bloody, if it was thick and tenacious, which means hard to take apart, if it was thin and liquidy. I want to note those things. I also want to note how much of it I got out of them. If I got a little tiny booger, whatever, I'm going to say that. Very minimal suction was performed and there was very minimal output. Um, and then I'm also going to say there was a large amount of thick, tenacious sputum suctioned from the left nostril. And I even note like which nostril I get more out of, because that's a good thing to pass on from nurse to nurse. We look at the coughing sounds and other airway noises. So we listen to the sound of the cough. Is it a dry, tight cough? Because that's going to indicate issues like asthma or allergic rhinitis, sometimes pharyngitis, that just icky sore throat, streppy sore throat that kids get. If we hear wet sounds, coarse sounds, and hacking, we want to note that. When we listen to the lungs, we have to be very careful to pay attention to the placement of our stethoscope and what we're actually hearing. So we want to note if the sounds, which they frequently are decreased in the lower areas, or if they're not present at all. If you can just kind of hear the sounds of the room through the stethoscope that's placed on their body. That can indicate like a collapsed lung or an airless portion, and we definitely don't like that. We want to note stridor and wheeze. So wheeze, as you guys know, is an expiratory sound. It usually happens on expiration. There is sometimes when you can hear a wheeze on inspiration, but it's not likely. Inspiratory sounds are stridor. When we hear stridor, that means upper airway is obstructed. It could be obstructed by mucus, it could be obstructed by swelling, it could be obstructed by an object. But it's the upper airway, and that is bad because that's like choking, right? So we want to listen for stridor. We want to listen for the wheeze. We want to listen for the crackles and the coarseness. You guys are definitely going to hear it if we have any respiratory kids on the unit. We're also going to look at their respiratory effort. So we look at depth, how much their body is sucking in or flaring out. So the depth, the quality of the respirations, are they shallow or are they deep? We want to look at how much work is put into it. Do we have a labored breath? Are they really putting a lot of accessory muscle use into getting that breath in or out? And then we also want to look at nasal flaring. You guys probably won't see that a whole lot in an adult, but we definitely see it in kids and infants. An increased work of breathing, like a lot of respiratory effort, that usually indicates lower respiratory involvement. When you note adventitious breath sounds, go to the wakelet that I've provided, and I'll put a link here for it. We want to listen to wheeze and note if it's found on inspiration or expiration. If you hear it in the upper the upper chest wall or the lower, and this can occur in asthma or viral infections. We also want to listen for rales, which is the crackling sound that you hear when the alveoli get filled with fluid, and we might hear rales with pneumonia. We want to watch for anxiety and restlessness. Children, just like adults, become very restless and have that impending sense of doom when they can't secure enough oxygen for their body to function. So we want to note those things that we see. We're going to look at fingers for clubbing. We don't see clubbing a lot in children and infants. They have to have chronic oxygen deprivation for quite a while of time to develop the clubbing in the fingers. We want to note their hydration status. Sometimes their nasal congestion interferes with their ability to be able to drink from a bottle or the breast, and even from a glass or a cup. So we need to be able to note if they are hydrated, and if they are not, is it because they're not eating or drinking because they can't breathe while they're doing it? We note whether they have tachypnea and increased work of breathing when they are crying as related to sitting still. So if a child is sitting still, not crying, not fussing, afebrile, and they're having tachypnea and increased work of breathing, that's pretty scary. If they are throwing a fit, I kind of expect tachypnea and work of breathing, right? So we have to be able to judge between the child that's just throwing a fit and the kid that's actually having a really hard time breathing. Okay, as far as labs and diagnostics, we don't do a lot of labs in pediatrics. Allergy testing is not done in an acute care setting. It's done as an outpatient at a provider's office. It's pretty brutal. They scratch your skin and then fill it full of disgusting allergens like pollen and dog hair and uh, tumbleweeds and oak trees and things like that. And then they wait to see how much of a reaction your skin's going to have. And it's pretty itchy and uncomfortable, and the process is just kind of mean. I haven't seen it done on a lot of children. Um, they tend to do it more in adolescence and adulthood. Um, ABGs, that is something that you will see spoken about frequently in a textbook, but in actual practice on a unit for acute care pediatrics, we would not do ABGs. If we are in a situation where we really think we need an ABG, that child should already be in the PICU or on their way there, because they become hypoxemic and they tank and develop respiratory compromise and failure much faster than an adult. So if we're worried, we should be sending them. Um, Chest x-rays, we don't do a lot of those either. Most of the time, the illnesses and the viruses that the children are coming in with respiratory issues, they we already know what the chest x-ray is going to show us if we look. So we would order a chest x-ray if the child was already hospitalized and we just really could not figure out why they're not getting better. Then we might do it. But we have to weigh the risk versus the benefit of exposing a young child to frequent or repeated radiation. We do a lot of nasopharyngeal swabbing, and we have to try. It is not an easy task. They fight you like a wildebeest, and they really hate it, and it can be pretty traumatic. Um, and that means that there are often a lot of very inaccurate nasopharyngeal swab testings done because whoever is performing the swab only swabs the very inside of the nostrils, and that's not an effective nasopharyngeal swab. So, like I said, it is traumatic, and we do it if we have to. A lot of times, we diagnose these kids based on their symptomatology rather than a laboratory or a diagnostic test. Peak expiratory flow meters and pulmonary function tests. Those are two completely different things. They're done in completely different ways for different reasons. But students tend to get them confused and mix them up together. So what I need you guys to do is to make sure that you write a note somewhere that peak expiratory flow meters is a daily diagnostic test used for asthmatics. So someone with asthma is going to go home with an expiratory flow meter. They're going to blow into it forcefully 3 times in a row and take the best measurement out of 3. And they're going to write that down on a little log. And they need to keep that log every day. And when they see their numbers becoming worse and worse, then they know that they are at risk of having a pretty severe asthma attack and they need to get on top of it. So a peak expiratory flow meter is a device that is sent home with a patient that is used by an asthmatic to gauge the ability of their body to exhale CO2 effectively. Like that's what it's doing. It's how hard can you exhale? How fast can you exhale? How much flow are you getting out of your body at one time? Because asthma is not a disease of inhalation. It is not um, trying to get air in. It is a disease of air trapping. So they are trying to get air and CO2 out, and they're unable to. So that's a peak expiratory flow meter. A pulmonary function test is done as an outpatient usually. I've never seen one ordered in a hospital setting. It is done as an outpatient in a pulmonologist's office. You go in, you sit in a weird little box. It's like a little glass box. And they plug your nose and you breathe in or blow out into this little tube. And at some point, you're blowing as hard as you possibly can, and it just like shuts off. It's the weirdest feeling. Anyways, pulmonary function tests are done to measure your tidal volume, your expiratory volume, your dead space, all of those things. So everything you learned in anatomy and physiology about the tidal volumes of the lungs, that's what a pulmonary function test is looking at. Pulse oximetry is a diagnostic tool that we use in the hospital setting. You guys are very aware of it. It is not an end-all be-all proof of illness or disease. I would rather in a acute care setting that you look at your patient more than you look at the number. So if your patient is satting a normal amount, like they're at 94 on room air, but they are working, we still need to treat them. So don't stare at the machines, look at your patient. We do a lot of rapid testing in the pediatric space, both as an outpatient in the emergency room and in the acute care setting, because we are ruling out things like influenza and strep, which obviously wreak some havoc on the respiratory system. So that's all I've got for you right now. Hope this helps.